All right, so let's just talk about liver assist devices in general. I'm going to talk about Mars, and we'll talk about ALAB. So before we get into this even, so this is something that I think we've spoken ad nauseum now, right? We've spoken about ALF versus ACLF. And the reason why I've put this in the slide deck is to remember that in ALF, any therapy can potentially have the effect of stabilizing function to such a degree that you can actually revert back to normal hepatic function because you have the property regenerating back to normal hepatic function. So as you think about endpoints of any therapy, including extracorporeal liver therapy, apart from transplant as a bridge, transplant, you think about bridge to spontaneous recovery. That's an ALF. ACLF, you have advanced scarring, advanced fibrosis, and alcoholic hepatitis will fall in this category. Because there is, if you stabilize enough and you catch it early, like in him, you can ship it back to spontaneous recovery. ACLF, you already have a lot of cirrhosis, a lot of underlying liver disease. So when you have an acute insult, you're not looking to bridge them to spontaneous recovery. The damage is done. What you're trying to do is bridge them for temporary stabilization and then eventually take them to potentially transplant. So just remember that again for any therapy, including potential extracorporeal liver therapy benefits, especially as we try to design future studies. I think this is an important thing about endpoints, how to define efficacy. All right, so let's talk about rationale. So let's say you have an acute insult. This could be ALF, ACLF, alcoholic hepatitis. Alcoholic hepatitis, but just by the way, is defined typically separately from ALF and ACLF. When you have liver injury, you can develop certain hepatic-specific toxins. So that's sort of the rationale, and we'll go over some of these potential sort of specific toxins. That leads to a couple of issues downstream. One is, and you see this typically, you've seen it in bed 18, you can see it in decompensated cirrhosis use, then develop multi-organ system failure. And you've seen this, you've seen hepatic encephalopathy, you've seen distributed shock, you've seen hepatorenal syndrome. And then in cirrhotics, you can also see the similar manifestations in ALF, as we just saw. The second thing that we think is happening is you have, in addition to this issue, you have a negative feedback loop on the potential for the liver to regenerate, especially in ALF. So impaired hepatic regeneration. So if you were to create a system that's able to detoxify, then you have the ability to have a double positive effect by mitigating or preventing multi-organ system failure as well as facilitating hepatic regeneration. And this, in a nutshell, as we talk about this in the context of the ELAD, is what we're trying to do in part, is mitigate this worsening multi-organ system failure and also sort of facilitating intrinsic regeneration. Now, this iteration of the ELAD study is choosing a less sicker population. And you wonder, the reason why they saw a benefit in a MELD less than 28 versus a MELD less than 35 is that the damage is not too far done. And so you have the ability to stabilize intrinsic hepatic function. All right, so just to put that all in context, here's ALF, ACLF. When you think about extracorporeal liver support, as far as endpoints of therapy, on ALF you think about intrinsic recovery or liver transplant. And here in this ICU you've done both. We have bridged folks to recovery, especially those who we haven't spoken about King's College criteria, but in ALF, if you're an INR greater than 6.5, if you have an advanced encephalopathy, the modeling would suggest they will typically die without liver transplant. But we've had cases where we've bridged successfully because you can't offer them transplant due to some psych history. They've done well. Or we have bridged them, actually quite a few cases, to liver transplantation. I think some of you may have seen this case of PNF that we also had in the corner pocket maybe last month. You were here for a primary non-function, so the liver didn't work.
Yeah.
Oh yeah, that was the beginning of our
Right.
The one who got retransplanted.
Yeah.
So that is actually, there was one first case of PNF I've seen in about 5 years. Here on the cirrhotic side, on ACLF, it's a bridge of temporary stabilization. So, for example, reversal of refractory hepatic encephalopathy is a good example. We have a single organ system down. We've also used it in bed 11 for hemodynamic. We tried that briefly on bed 18. Or as a bridge to liver transplantation. So just going into systems, as far as terminology, this is artificial. So you have artificial and bioartificial. Mars is an example of artificial because you don't have hepatocytes in the circuit. ELAD is an example of bioartificial, you actually have hepatocytes in the circuit. So let's just talk about Mars. So Mars is, I think you've had some lectures on albumin, but in addition to volume expansion that we normally think about in critical care, especially in cirrhotics, because it's actually been well studied that in addition to quantitative dysfunction, so you have an albumin like 1.5, you also have qualitative dysfunction, so the albumin binding sites are compromised. And there's actually some albumin binding studies you can do that are compromised in cirrhosis. So it serves got multiple binding sites, especially it's got disulfide bonds that can go between redox states. They can really be efficient in binding various drugs, and so our pharmacists know more about this than we do as far as certain highly protein-bound drugs are used in Norvasc toxicity, for example. We've actually used NORs very efficiently to scavenge. Other calcium channel blocker toxicity. And this is where you talk about elimination of toxins. And we'll talk about a whole list of toxins that accumulate that are albumin-bound. They will not come off with CRT. They'll actually come off with Mars, and so that's an interesting chart to look at. This is what it stands for, molecular adsorbent recirculating system. So just to put this in the sort of a more of a microscopic version, so here is your dialysis membrane. The first Mars dialysis membrane that you'll see. Just to orient you, here's the patient's plasma side, here's the dialysate side. A couple of differences, so I would compare it to CRT. So the first big difference is you see is that this is a albumin dialysate. It's not a bicarbonate or an aqueous dialysate, it's a 16% albumin solution. The second difference is that the pore size is different. In addition to these small, low molecular weight substances like potassium, BU, and creatinine, which normally come off with CRT, which are denoted by these circles, you also have the transfer of these triangular molecules, which are supposed to denote specific albumin-bound toxins. So you change the pore size, and you change the dialysate, so you suddenly create a gradient for these albumin-bound toxins to start crossing. Examples of these will be bilirubin, free fatty acids, endogenous benzodiazepines, is an interesting example, which may be the reason why it works so well in hepatic encephalopathy. And so suddenly you create a membrane that can filter not only these traditional CRT cleared molecules, but also this second class of molecules. So that in a nutshell is sort of the mechanistic rationale for what are we doing. So this is interesting, I think, a chart that, so on the right side, is water-soluble substances which will come off with CRT. So I think you recognize these, creatinine, BUN, TNF-alpha, and then interestingly ammonia can come off here, but if you may wonder why we don't use CRT a lot for ALF, there's one study that if you really crank up your dialysis dose, you can really actually eliminate ammonia, not of the flow rates that we have here. On the left side is a host of other molecules that comes off with Mars that will not come off with CRT. So endogenous benzodiazepines, bilirubin, you've sort of seen this a few times here, is we've done a lot of drug-induced liver injury cases, billies of 60, 70, that will not come off with CRT, that will come off beautifully with Mars. And again, it's all about stabilization of the acute event, and then the intrinsic liver kicks in. Medium and short chain fatty acids have been invoked in sort of the surge response and sort of distributed shock. Nitric oxide is interesting. Anecdotally, we've used for hemodynamic stabilization, especially now that we're able to do it continuously. We've actually had some success with this is more anecdotal, but I think what I've become a big believer in is refractory HE in cirrhotics. Let's just go over the circuit. So this is regular dialysis, CRT, right? You have one membrane. Patient's blood flows across here, and the dialysate, which is aqueous bicarbonate base, goes the other way. Contrast this with the Mars circuit. So here you have two membranes. Right away you see difference, right? The first membrane is the one that I've shown you before, which has an albumin dialysate that's denoted in yellow. So here the patient's blood sees this albumin dialysate, and you have transfer of both aqueous and albumin-bound toxins coming across here. So then the effluent comes off here and then gets sequentially cleansed to regular CRT membrane, so the prismaflex is there. So you get CRT to boot. And so what comes out of here, so the BUN, creatinine, all this stuff comes off here. And then what's left here is the albumin-bound toxins like bilirubin, free fatty acids, and that gets sequentially cleansed through a charcoal column and ion exchange column. And the ion exchange column is actually the one that extracts the bilirubin, the charged molecule. I'll show you an example of a case that we did. So that's the difference. And again, from a flow rate standpoint, if somebody tolerates CRT, they will tolerate this. Because remember, we've been cranking up our blood flows to 200, 250 on our CRT. This is a fixed blood flow of 180. So from a hemodynamic standpoint, if somebody can tolerate CRT, they can tolerate Mars. So from a safety profile, no issues. We have been using citrate anticoagulation until about recently, but now we even sort of, since this whole Prismaflex technology has changed it sort of to be compatible with Mars, we're actually doing citrate-free now as our initial starting point. I'm going to skip this for a second time. So you've seen this machine at the bedside, but just to show you that it's so compact compared to what you're going to see in that room. And it just goes in series. This is the older Prisma machine that we had. Now it's changed to Prismaflex. This is the initial membrane. This is the second membrane. That is your ion exchange column. This is your chocolate column. So this is just an example of this bilirubin extraction. So that's your ion exchange column to start. And this is a case of somebody had a bilirubin of almost 60, 65. And just within 3 sessions, the bilirubin went down to 10. So this slide needs to be a bit updated, but this is actually FDA approved for ALF, due drugs or toxins. We're actually the busiest center in the country right now. We've done about maybe close to 100 cases over the past 2 years, 5 years. I put this in italics because for some reason, the company is changing hands. This indication is not FDA approved anymore, even though I think there's more data. There's an RCT to actually support this. And personally, as I said, based on my experience I think this really works well. The other thing I just should mention is, since we have the ability to do continuous Mars, this is working really well, apart from about 18 years. So, to stabilize hepatic encephalopathy in ALF, we have folks with on-R of greater than 11, basically anhepatic state, where we've maintained the hepatic encephalopathy of grade 2. Now that's a big deal, especially if you're trying to prevent cerebral herniation and you're trying to bridge them to transplant. Because the moment you intubate, you lose your neurologic exam. And then you're sort of scratching your head if you don't have an ICP monitor, what is the ICP? Especially as you're trying to work them up for transplant. And you can have some pretty bad neurologic intraop events. So this is, I think, exciting way we can do continuous Mars in pure ALF, stabilize the neurologic function in an anhepatic state, and bridge them. And that may go back to this endogenous benzodiazepines scavenger. This has got to be updated, right? So we used to do this, we didn't have 24/7 staffing, but now we're going to. It's almost continuous. That's the albumin dialysis. You just mix albumin and saline. You got to exchange the Mars cartridge after 8 hours, and then this again may be a non-issue. We typically, especially for ALF, we've been continuing the CRT in between the Mars sessions when we're doing intermittent, with a goal to maintain this homeostasis. But now that we've gone to continuous Mars, this is a moot point. They keep getting CRT. Again, this is in sort of evolution as well. I made a decision not to use heparin because you remember that we spoke about systemic versus regional anticoagulation. I was just trying to avoid the heparin effects in the INR, because it does affect it to some degree. So while you're sitting with an INR of 10, and there's a separate conversation, what does an INR of 10 mean? It doesn't necessarily mean they're auto-anticoagulated. We're just trying to eliminate the heparin effects as you're trying to track the INR to prognosticate. So that's all good and well and good. He says, what is the data? Again, a lot of it is case reports and case series. We'll show you a couple of a few RCTs. So this works really well. We've actually had folks just ship in just for refractory pruritus because you extract the bile acids that are causing. This is anecdotal. The case reports of this, I've sort of had mixed benefit with hemodynamic stability, but I'm interested now that we have continuous Mars. It may be a supply and demand issue, right? So you do intermittent Mars, are you scavenging enough vasoactive molecules with intermittent Mars and not therefore achieving your hemodynamic benefit? Now that you have continuous Mars, it'll be interesting to see if we really make a dent in stabilizing blood pressure. Because in the end of the day, it's all, in many cases, about stabilizing the blood pressure enough to take them to transplant. We had this conversation yesterday about about bed 18 was to see if we can get her down to 0.1 plus vaso, right? Which didn't happen, but reduction in portal pressure, there's a reduction when you have ICP monitors. You can actually, and this may be what we're seeing in our experience, right? We do continuous Mars, we prevent progression of encephalopathy, which correlates in ALF with ICP. So if you're grade 4, it'll definitely have an ICP higher than a grade 2. We know that. So this may be just a non-invasive way of seeing the same thing. And this hepatic encephalopathy in ACLF, that's actually based on randomized controls. So this is some HRS data, benefit. And this is something that our pharmacy colleagues, I think, would have specific interest in. And I've started seeing this. The question is, now you've changed your extraction parameters based on compared to CRT. So now you can extract albumin-bound drugs, meds as well, right? So interestingly, N-acetylcysteine is highly protein-bound. So how are we affecting delivery of NAC in ALF? I don't know. There's case reports, if you look at, there's highly protein vancomycin, pick any highly protein-bound drug. And so it really changes the equation, meropenem. So this is the RCTs, right? So not many. So this is just columns. This is all mostly European studies. There's one from North America, 2002. So this is just the last one came out in 2013. Mostly cirrhotics, ACLF. The last one was ALF. Not big sample size. It's a hard disease process to sort of study, but especially ALF. But this is the biggest study. And the primary endpoints for these studies were typically survival, and it's a separate conversation where I think we should look at non-survival endpoints to define efficacy. Because I don't think I want to look at 28-day mortality in a sick patient like this. I think it'll be stabilization of HE as you present a transplant. I think that's where you look at the efficacy definition. But having said that, small sample size, I don't know what to make of that. It's the only positive survival study. This is, I think, a big one. Again, N of 70, looking at Mars versus standard of care. And this showed a 2-grade improvement, non-survival endpoint. This was a big study. Again, I would argue that this is not the endpoint to look at. 28-day survival in a sick ACLF group. No. And then lastly, this is the first study in ALF, 102 patients, French multi-center study. For some reason, it shows a survival of 6 months. 6-month survival is a primary endpoint. Again, no benefit, but the caveat to this study was upwards of 75% of their patients, both in the control arm and the treatment arm, got transplanted. Maybe the French have got a lot of livers floating around, but so that was a confounder, right? So that was a huge confounder as far as you take away the ability to study Mars efficacy. I mean, they saw less than 24 hours of Mars. Everyone went to transplant. So anyway, that is the state of affairs as far as sort of high-level evidence. So I think there's an opportunity to sort of redefine how we think about defining efficacy. I think the important point, when we look at any new drug, new device, you're looking at, especially phase 2 studies, looking at safety as well, right? So safety and efficacy, that's a big, and as for the reasons I mentioned, based on blood flow, you will not, if you tolerate CRT, you will tolerate Mars from a hemodynamic standpoint. It's very safe. Having said that, this one anecdotal case of what we think was a possible anaphylactoid reaction, which can happen with any membrane. This is the second one I've seen in maybe 100 runs here. All right, so based on all that, this is what we use it for here in 5E. So bridge to spontaneous recovery in ALF. So if for some reason our transplant candidate reverse them. Bridge to transplant. We've done this a fair amount, typically in ACLF and in ALF. HE, ACLF, I think that's a big one. And then this is more homeopathic, but intractable varieties. All right, and then ELAD, I think we've already spoken about, but I won't get into this. But just to regroup on the circuit, blood flow comes out. You see a catheter was already in. You'll see a separate separation into a plasma circuit, and you'll see these cartridges lining up there, and this will become much clearer when you see the circuit itself. And then the one thing you'll notice, you'll have a readout of all physiologic variables of these cells: pH, PCO2, PO2, they'll look at cell viability throughout the 5 days. And they have created this technology where these 4 cartridges can actually survive and maintain function. And the one thing you look at is glucose consumption. That's one thing pre and post. And so as long as these cells are avidly consuming sugar, you know that they're metabolically active. And based on their pH as well. So they have their own oxygenator and their own dextrose source. We briefly spoke about this yesterday, but this is about, if you put these 4 cartridges together, it's about 440 grams of hepatocytes, which is about 30% of the liver. In case you're wondering how much you're trying to put in there. 30% liver mass for an average person. So that's sort of the treatment dose, if you will. And we spoke about this as well. This is a cross-section of this membrane. And as opposed to Mars, where you had you're invoking a dialysate to create a diffusion gradient, this is purely passive flow of plasma through these pores. Here are these cells that will secrete and maintain all the functions of hepatocytes, and you just have bidirectional transfer of molecules. And we went over these slides yesterday, but it's human, so no zoonoses concerns, very stable. This actually is getting shipped from San Diego overnight, so must have arrived today. It's immortalized, but it's still can get multiple passages, but it's retaining all the cell functions. P450 enzyme activity, synthesizing all these proteins that we spoke about, including albumin, alpha-fetoprotein factor levels. So there's you might see an iron, in case you had a coagulopathy, that should get better. And this is what it looks like at the bedside. And this will become more clear. I won't belabor the circuit here, but I think it'll be good for you to just pop in there and just take a look at. We spoke about this as well. And just to recap on this is the first study that looked at a sicker alcoholic hepatitis patient population. And the primary endpoint was survival to 90 days. No difference between the ELAD curve, which is pink, and the control group, which is blue. But then if you look at a subgroup analysis, predefined, and this is what he's falling into, is a male less than, this is actually male less than 28, but it is less than that. You had a sort of a score that was trending towards statistical significance. Here they're younger, age less than 50, male less than 30, creatinine less than 1.3, iron less than 2.5. So the rationale is that if you catch them even earlier, that may be where you can make a benefit. You want to take an alcoholic hepatitis who's sort of sitting at a mel of 35 and try to bring them back. All right. Questions?
What do you think is the main benefit of ELAD?
To be determined.
Compared to just regular?
If you look at, I skipped over this slide, but if you look at this profile, they've actually done studies throughout this, but this is, if you look at the continuum of fibrosis or cirrhosis, right? So this spectrum is no fibrosis, acute liver failure. Mm-hmm. On this spectrum at this end of the spectrum is advanced cirrhosis. So mel to 35, 40, some of the people with transplanting. So the proposed ELAD's target population is to go towards less sick liver disease. So we've actually done studies in ALF looking at acute liver failure, surgery, we define surgery-induced liver failure, hepatectomy, for example, or partial. And alcoholic liver disease falls in this category of reversibility. And so, where is this cutoff? I think it's a moving target. I mean, we can sort of say with based on the study, mel less than 30, mel less than 28. But you want to, maybe the target population for ELAD is those folks who have some potential for intrinsic hepatic recovery and not advanced chronic liver disease with a high mel. But I think let's say the study works, then it gets into market in select centers because you'll see the system is pretty complex. I don't think it's going to hit, it's not CRT, it's going to hit every hospital. It's going to be in certain centers of specialization. And then once you prove efficacy in one disease process, then it's going to use off-label, right, for others. All right.